Thank you for being with us on this morning, and it's always nice to see a lot of people in a dry eye session. I think my previous speakers have made my job very easy, so I'll pick up the string from where Dr. Radhika left it. So my task today is to tell you how to go about choosing an artificial teardrop, and believe me, that's how I always land up wherever you look at a challenging case in your clinic, because the options are all so confusing. You have the industry bombarding us with so many medications, and one is always left or spoiled for choices so badly that you really do not know what is the right choice which is going to be working optimally or increase the success rate of your management of a particular case of dry eye disease. So what you look at what are the constituents of a particular dry eye medication is going to be the polymer in the medication, it's going to be the preservative in the medication, and it's going to be the buffer agent or the oil or the gelling agents which add on to the tonicity and the viscosity of the medication which you're going to be using for the particular patient. So this is a busy slide here, a wonderful flow chart which sort of summarizes what medication is perhaps going to be better or best, and it has to be applied in what scenario of the dry eye disease. So as we all know that there are two components of an evaporative dry eye disease or a tear deficient dry eye disease, and these could be caused by multifactorial morbidities here. So what particularly needs to be addressed when you're looking at a patient is what is the problem which is causing this dry eye manifestation in this particular patient who's sitting in front of you and is being unhappy and moving from one doctor to another doctor perhaps. So you have to identify that in order to be successful to the kind of medication you need to choose for this particular patient. But remember, the bottom line is whatever be the morbidity which is causing, what it is particularly doing is altering the tonicity of the tears. So it's making your tears hypertonic, or the osmolarity of the tears is getting altered by this particular disease, and this altered hypertonicity or the hyperosmolarity of the tears fits into a particularly vicious cycle, which is what leading to the symptoms by nature of which the patient is presenting to us. So it's tear hyperosmolarity leading on to inflammation, release of inflammatory mediators, and those indirectly or directly damaging the ocular surface, the tear film and the ocular surface epithelial cells, contributing or worsening to the tear film instability. So once you understand this particular vicious cycle and you're able to identify at what phase of this cycle the patient is presenting to you, you would probably be nail on, or you will be able to target your therapy better and bring in a better success for your particular patient. Just a small word is today understanding tear film has become more complex. It's a complex entity now, so it's not just a simple thing which is altering. It's been broken down to a complex molecular understanding. I'll leave you to go back and read those to enhance your understanding. But what has changed today in the management of dry eye is moving from looking at a patient when he is symptomatic and managing a dry eye disease when the patient is becoming asymptomatic to us. That is, before he is going to manifest with significant ocular surface damage. That is when you want to identify, pick him up and treat for better success and decrease the morbidity of the disease. Practically what we are seeing today in most of our practices, I'm not going to talk to you about the particular or the severe ocular morbidity diseases which cause dry eye disease, but by and large which most of the practitioners would see in your practice is your meibomian gland disease and which causes an evaporative dry eye disease and an aqueous deficiency dry eye disease. You would see by and large there is about a 30 to 70% overlap. So you might have one of these two components in the particular patient you are looking at, and just addressing one perhaps is not going to be useful in managing this. So these are the various factors you need to look at. You need to look at the polymer, what is the preservative, what is the electrolyte content in the drop you're choosing, what is the osmolarity, how is it going to change by using this medication, what is the viscosity of this. Of course, cost plays a major factor, but by and large what I still feel is what is the patient comfortable with on using it. What works in one perhaps does not work in the other. So this is how these various factors which I spoke to you about function in enhancing the ocular surface or enhancing the comfort of the ocular surface. To make it more practical is what are the factors you need to consider when you're choosing eye drops for therapy for dry eye. Factor one is please do not use any medications which are going to decrease conjunctival hyperemia. These vasoconstricting agents is not going to help, and it's going to probably is going to give you a little dry eye, but the patient is not going to be comfortable in the long run. Two is identify what is important, and I think Dr. Muscati wonderfully showed those clinical sites to say identify what is the pathology you're dealing with, and unless and until you're going to hit target on managing that pathology, just giving lubricant drops is not going to be the answer. It's going to be a short-lived comfort for the patient. He's going to come back to you, I was happy the first week, I was happy the first 10 days, but I'm not happy anymore, doctor, and you're not able to treat me. So that is by and large the most important reason why it fails. And three again is if there is a particular disease which needs long-term medications, and most of our patients are chronic glaucoma patients, and chronic glaucoma medications and the preservatives in those medications or any other disease which is warranting long-term therapy can lead to the preservative induced damage, and that's something which needs to be taken care of. I'll shortly come on to that. And the other factor you need to look at is whether you need to do just drops or whether you have to give ointments for these patients. So what are the polymers you have with them? You are again spoiled for choices. You have HPMC, CMCs, carbomers, polyvinyl alcohols, pyrrolidins, and hyaluronic acids, dextrans. So the choices are multiple here, and you have they are basically based on two classifications, whether they are neutral charge particles or polyelectrolyte charge particles, all performing the very important task of enhancing the ocular surface viscosity here and also improving the wettability of the ocular surface. And most of them come by and large with some form of a true preservative-free medication. It's still by and large not a reality. They do come back with a lot of preservatives. So that's something you need to consider. What is the preservative in this, and is it going to add on to the toxicity of what this patient is already using? This was a wonderful study when I basically went back and looked into what polymer is perhaps better than the other polymer. I have so many company people coming and sitting in my office and telling me to use this or that. So I went in and read this particular paper, and I would recommend you to look at this as well. And this talks about complex calculations which are beyond my comprehensive understanding here. But then the bottom line or the take-home message it gives you, it talked about the comfort indices, calculation of comfort indices using various medications, which is a wonderfully done research here. And to my pleasant surprise, I did find that the comfort index of hydroxypropyl methyl cellulose and carboxymethyl cellulose, HPMC, still seem to score slightly over the OCMC. That's why I always wondered my patients, when they are still on HPMC, which was one of the earlier introductions, are still happy with what they are using, because the comfort index values of these are almost as similar as well. But what we have in the almometer is the newer one, is the hyaluronic acid here, which has a better wettability and a better retainability on the ocular surface and a better comfort index compared to the others which we have with us today. So by and large, this is the pyramid which you need to concentrate on when you're choosing medications. And what does your medication need to do is to increase the already damaged tear film thickness, protect the ocular surface epithelial cells from further drying, help in the retention of the surface on the ocular surface, protect the ocular surface as well, retain or bring back the physiological conditions of the tear and the corneal thickness, improve goblet cell function, and relieve dry eye symptoms out here. So what you need to understand, this is a normal ocular surface here, but because of the hypertonic damage, the surface breaks down, the epithelial cells undergo desiccation, leading to damage, corneal staining and conjunctival staining. So when you are giving a drop here, what happens, it tends to rejuvenate and close up all these cracks which you, if you have to put it in layman's language, on the surface. But what happens is, as soon as the stress is removed, then everything gets fine. But when the stress comes back, then these eyes do not work very well. So that's why we need to look on those which contain polyols, and these polyols are amino acids which are additives on the tears, which do get into the cells and help to retain intracellular osmotic strength without damaging the proteins of the cells, and thereby enhance the effect of the medication which you are looking at. This by and large is the latest which is available on international literature, which is a PACE bulletin. Is a recommendation of what medication you would like to choose first, why and when, which will be the first line, second line. So go back and do read about them. I think lack of time, I will stop short here on how hyaluronic acid works, and I'll just move on, just a couple of slides to show on cyclosporin here, out here, because that's something which many of us are using as immunomodulating medications in our practice here. And what we actually are looking at, or when will cyclosporin act, is cyclosporin does not act in very severe dry eyes. It will be useful in mild and moderate dry eye disease where there is a persisting low-grade inflammation on the ocular surface, and you use it as a steroid-sparing agent to control the ocular surface inflammation and to produce an immunomodulating effect. So that's when cyclosporin is going to be effective by virtue of it being a powerful T-cell modulator, inhibiting T-cells and interleukin-2 release. So that's when you have to understand that cyclosporin is not there for all patients, and this is the particular bracket of dry eye disease patients who are going to be benefiting when there is a lacrimal gland disease, when there is a tear deficient disease completely. You're not going to have your cyclosporin working at all. So it particularly works well in contact lens intolerant patients with dry eye disease, in chronic VKC patients where the morbidity had led on to a dry eye disease, atopic keratoconjunctivitis, allergic conjunctivitis, superior limbic conjunctivitis. And just to close with a small study which we looked at to see if this is really helping, it does help in chronic glaucoma patients who are on anti-glaucoma therapy for a long while. And when we did look at their ocular surface imaging, we looked at the corneal imaging by their subepithelial nerve fiber layer plexus imaging, we did find that there was a definite increase in the corneal subbasal nerve fiber layer we did it before using cyclosporin and after using cyclosporin. So that the inflammatory component, when it gets controlled, is affording better health of the ocular surface, better health of the nerves innervating the ocular surface, and that is a sort of targeting or helping in improving the pathogenesis of a dry eye disease. So this in a nutshell is to help you to understand how to tailor your medications to better effect in managing your dry eye patients. Thank you for your patience.